for more global awareness videos. Happy International Women's Day. International Women's Day. International Women's Day. International Women's Day.
Project manager? Yes.
International Women's Day.
Project manager? Yes.
Every year on March 8th, the world comes together to celebrate the strength, achievements, and contributions of women. International Women's Day is not just a celebration. It's a powerful reminder that equality benefits everyone. In this video, we'll explore the International Women's Day 2026 theme, Give to Gain, its meaning, and how it can create real change. What is International Women's Day? International Women's Day is observed annually on March 8th to recognize women's social, economic, cultural, International Women's Day. International Women's Day is observed annually on March 8th to recognize women's social, economic, cultural, International Women's Day. International Women's Day is observed annually on March 8th to recognize women's social, economic, cultural,
Good morning, everyone, depending on where you're joining us from.
Good morning.
You're welcome to today's webinar. We are starting at 12. Good morning, everyone, depending on where you're joining us from.
Good
Please
morning.
talk to us through the welcome to today's webinar. We are starting at 12. Just tell us where you are
Depending on where you're joining us from.
You can
Good
introduce
morning.
the chat box through your name, the city where you're joining us from, and the country. We would like to hear from you.
Depending on where you're joining us from.
You can
Good
introduce
morning.
the chat box through your name, the city where you're joining us from, and the country. We would like to hear from you.
Depending on where you're joining
Good morning, stroke good afternoon, everyone. I hope you can all hear me.
Yes.
Okay, so I'm Jeanette, one of the moderators for today's webinar. As we wait for my partner Juliet to come back again, welcome once more to the PCOS webinar, where we're going to be expounding more on what it is, the myths and misconceptions, and more further introduction on it will be done by Juliet. So let's give her like 5 minutes max, and then we can continue as we also wait for other participants to join. Thank you.
And political achievements. It also highlights the ongoing challenges women face worldwide, from unequal pay and limited education to gender-based violence and discrimination. The theme for International Women's Day 2026 is Give to Gain. This powerful message emphasizes a simple but impactful idea. When we give support, opportunities, and resources to women, everyone gains: families, communities, economies, and future generations. Give to Gain encourages individuals, organizations, and governments to actively invest in women's empowerment. Giving does not always mean money. It can be time, education, mentorship, equal opportunities, safety, or a voice at the decision-making table. There are many clear ways to help women get ahead at work, at home, and in the community. Here are some fantastic ways to help the IWD 2026 Give to Gain campaign during the entire year. Give respect. Value women's ideas, choices, and leadership. Give donations. Support causes that uplift women and girls. Give visibility. Highlight women's achievements and voices. Give knowledge. Share education, skills, and information. Give funding. Invest in women-led initiatives and businesses. Give justice. Stand for fairness, rights, and equality. Give resources. Provide tools women need to succeed. Give a voice. Let women speak and be heard. Give protection. Ensure safety at work, home, and online. Give truth. Challenge myths and misinformation.
Juliet, you can start.
Hello, good afternoon once again.
Good afternoon.
I
Good
hope everyone
afternoon.
is well. I hope everyone is well. Thank you for joining us in today's webinar. We're happy to have you all. We're glad to hear from you, everyone. On behalf of the CEO of Jonica Foundation, Mrs. Veronica Johnson, and the founding director, Dr. Shola, allow me to say welcome. Where if you are in Kenya, I'll say karibu. If you are not within Kenya, I'll say welcome so much, and we are glad to have you all in today's webinar about redefining PCOS as a SRHR priority beyond the myths. And just to keep you engaged through the chat box, please allow us to know where you're joining us from, and just share your thoughts through the chat box. We'll have a look as we proceed. Just a while. Okay. Okay, just a while. I'm sharing my screen in a short while. Okay. I'm sorting out something shortly. Just a while. All right. Just let's proceed. So today's webinar, as I mentioned earlier, we are redefining PCOS as SRH priority beyond the myths. Briefly, I'll begin by sharing what is Jonica Foundation, just to give an overview of Jonica Foundation to allow us just to just have a brief idea or maybe knowledge about Jonica Foundation. So Jonica Foundation, our mission is basically to empower vulnerable mothers in Kenya to heal and rise and build sustainable futures. And we are currently operating in five counties. If you've had an opportunity to interact with our website, we are operating in Nairobi, Kiambu, Narok, Kilifi, and Homa Bay. And I believe some of our participants who are joining us could be based in those different counties. So we have 4 programs. One of the programs, we call it Mwili Wangu. Mwili Wangu basically talks about empowering women with knowledge, health, information, and SRHR programs. Then we have a program we call Sauti ya Mama, which is a community storytelling event, which is normally done in open spaces, in workshops. like what we're doing today through webinars and podcast series, where we provide safe spaces for women voices. Then we have a program called Imarika program, which basically does strengthening of SRHR referral pathways to women to enable them to access services faster with dignity. Then the last program, the fourth program, we have Pamoja Path, which is an M&E program that is monitoring and evaluation that measures the impact and continuity to improve our work throughout the counties. Today's objective, we are aiming at creating or increasing awareness of PCOS signs, symptoms, and health implications. That's why we are redefining PCOS. Then the other aspect is to debunk myths and misinformation that fuel stigma and prevent care seeking. Then the other aspect on our objectives is to amplify lived experiences. That's why as we continue through our webinar, we'll have to hear from the lived experiences amongst some of us who are attending today's webinar, so that we foster community support. And then the other aspect is promoting respectful evidence and informed SRHR care. Then the last one is to position Mwili Wangu for sustained advocacy and support. So today, our webinar is really packed. We have a lot of experienced speakers, and you just can't wait to hear from them. Personally, I'm also looking forward to hearing from them. Yes, just keep the chats live. Keep the chats alive. Talk about maybe what you are expecting to hear, what your expectation for today, and what you love to hear from us. So we have 4 speakers on board today. So the first speaker will be Dr. Zipporah Amecha. Dr. Zipporah Amecha is also one of our board members at Jonica Foundation. So Dr. Zipporah will be talking about PCOS health. Is a PCOS healthcare provider, and will be talking about the basic meaning of PCOS, science, myths, and myths and versus the facts. So I hope every one of us is really looking forward to hearing from her. Then we also have Dr. Neema Chacha. Dr. Neema Chacha is a wellness consultant based at Nairobi, the Nairobi Hospital. It's the Nairobi Hospital. So she will take us through diagnostic criteria, ultrasound, and hormonal facts. Then we have Ajay. Allow me to call her Ajay. She's from Ghana. She will also be taking us through the lifestyle, mental health, living with PCOS. So I hope all of us are really expectant, like myself, looking forward to getting to learn more from our speakers and just to get more information. So without taking much time, drum rolls from in the chat box. You can send your love emojis, you can clap, and just however you may react, you can react from the chat box. Let's do some drum rolls for our first speaker, who is Dr. Zipporah Amecha, a PCOS healthcare provider and also a board member at Jonica Foundation. Please allow me to welcome her as she takes over the podium to take us through the basic meaning of PCOS, science, and myths versus facts. Let's welcome her with a round of applause, drum rolls, and love emojis in the chat box as we welcome her to take the stage. Thank you. Welcome, Daktari.
Thank you, Juliet. I'm audible. Am I audible?
But, somehow breaking. I'm trying to. Can you hear me? Yes. Can you hear me?
Yeah, I can hear you. Am I clear now?
Yes, please proceed.
Better?
Yes, you're clear.
Yeah, thank you so much, Juliet, for the great introduction. So as Juliet has said, I'll be dealing with the definition. So the comprehensive definition of polycystic ovarian syndrome, and I'll be dealing with the signs and symptoms and also the facts, the myths against the facts about polycystic ovarian syndrome. So maybe just a little introduction. I am Dr. Zipporah, and I've been researching on polycystic ovarian syndrome for a while. And I am, during my undergraduate project, that is the project that I did a project on polycystic ovarian syndrome. And I think it's a long time of interest. I've been having an interest for a long time. And so I think I have information, and we'll be able to interact from now on. Now that this is our first meeting, I was very excited about it. So I'll share my screen because it's a presentation. I don't know if that's possible. Can you kindly allow me share? Juliet?
I'm on it, just a
Yes,
minute.
sorry.
So I will be very brief. I think I have 15 minutes. I'll be brief, but I will do a very great job to help us understand, because I know we are not only medics here, we also have our, how do I say, our women that are also concerned and interested in polycystic ovarian syndrome. So it will be layman's language. The presentation is layman's language and straight to the point. You can read through the points, but I will be explaining most of the time. So whenever I am ready to share, you can allow me.
Can you try now?
So my share button is still inactive. I don't know if it's a problem on my side. It is still not going through.
Okay, you can just explain then as we sort it out.
Okay, no problem. So I'll begin. So on the definition of polycystic ovarian syndrome, so I know we have different types of definitions when it comes to polycystic ovarian syndrome, depending on who you have come across, who has told you about polycystic ovarian syndrome, but the real definition and the most comprehensive definition is that polycystic ovarian syndrome is a complex and it's heterogeneous. So it is heterogeneous and it's an endocrine. It's an endocrine metabolic syndrome. So you might think that it's just a reproductive syndrome, but it is an endocrine and a metabolic syndrome affecting women of reproductive age. So the reason why we call it heterogeneous in a medical aspect is that patients do not all present the same way. So you will have people presenting in different symptoms and signs. So you have somebody having the polycystic ovaries, some will not have them, and some will have the facial hair, some will have irregular periods, some will have amenorrhea completely. So these differ from patient to patient, and then they may also, the causes also differ. As we look at it later, causes are different. Some are genetic, some are due to lifestyle, but causes are also differing. So that is the reason why it's called heterogeneous. Another reason it's called heterogeneous is because symptoms and severity also varies. Some people are extreme, some are just mild. And then the underlying mechanism is also not identical to all patients or all clients. So when it comes to the syndrome, the reason why it's called a syndrome and not a disorder, normally in medicine, disorders are diseases that are caused by one causative agent. So for example, malaria is caused by Plasmodium falciparum, for example. But when it comes to polycystic ovarian syndrome, we don't have a specific agent or a specific trigger to say that this is what causes it. So that's why it is called a syndrome, because it is a collection of signs and symptoms from different or multiple mechanisms of the body. So the mechanisms that are involved are linked to the signs and symptoms. So symptoms and signs are different, as we have said. And when it comes to polycystic ovarian syndrome, the systems or the mechanisms that characterize this condition or syndrome is, number one, reproductive features. So apart from having irregular periods, some people could have regular periods, but they are not ovulating. So you can have what you call chronic anovulation, where we have irregular menstrual cycles, where we have oligonorrhea, where we have somebody having a cycle that is more than 35 days. And then we can have amenorrhea, where somebody can even have secondary amenorrhea and they have not seen their periods or their menses for around more than even a year, some even for more than 3 years. I know we don't speak up because there's some stigma attached to that, or some kind of feeling inadequate as a woman, so we don't really speak about it plainly, but there are people who can have secondary amenorrhea to even years and years and they've never seen their period, or they must use contraceptives to have their period. Another reproductive feature is infertility, although it is not a fact that all people who are infertile is because of PCOS, or polycystic ovarian syndrome is not the main, is not as in the only cause of infertility, but it can be a reproductive feature. So feature number 2 is androgenism. That is where now you have pronounced male features. So for example, you can have facial hair or a very oily face. So when it comes to the clinicals, the ones that you see on the surface are that you will see acne because of the oiliness of your skin, and then you will see facial hair. Sometimes you may undergo alopecia, where we have hair residing, like the male version of hair residing and becoming bald. So apart from that, we have another mechanism is the polycystic ovaries. So some people have the ovaries that are polycystic, which are usually multiple follicles that don't mature. So you can, when you go for an ultrasound, you can see that some people don't have, but they still have polycystic ovarian syndrome. And lastly, we have metabolic disturbances, where we have insulin resistance. And as we know, or maybe the medics know, and maybe you've heard from social media, maybe we like to discourage that, but we know that insulin resistance is the main driver, or it drives polycystic ovarian syndrome. So we have the insulin resistance, and because of insulin resistance, we have compensatory hyperinsulinemia, where we have so high free insulin in the body because it's not being utilized by our muscle cells. And then we have obesity, but that is not a fact sometimes, because even lean people still have polycystic ovarian syndrome. So those are the mechanisms that are linked to polycystic ovarian syndrome on the definition. So as I've spoken about the definition, you will note that most of the symptoms come from the definition that I've already explained. But the signs and symptoms, as we've said, they are heterogeneous. They vary from one person to another. So on the signs and symptoms, we have menstrual and ovulatory dysfunction, which I've already explained. So some people will have an ovulation and they're not able to ovulate. Therefore, it becomes difficult for them to conceive. But we later on see what causes that. So as I said, we have oligonorrhea, where we have cycles that are longer than 35 days, and amenorrhea, where we don't have periods or menses for more than 3 months, or we have irregular and unpredictable periods, or heavy and prolonged periods. So it can go both sides. And the mechanism for this anovulatory dysfunction or menstrual dysfunction is because of our luteinizing hormone. So the luteinizing hormone, once it is in excess and you have also excess insulin, you have your ovarian thicker cells produce androgens. So you know, in the female body, you have both the male hormones and female hormones, but in a good balance for you to function as a lady or as a female. So you find that when it comes to PCOS and in the menstrual dysfunction, the luteinizing hormone is excess and the insulin is excess. Therefore, the ovaries produce a lot of testosterone. So you will have a lot of free testosterone in our body, and therefore we have follicular arrest, and there's no dominant follicle, and therefore there's no ovulation because of the low luteinizing hormone. So apart from the menstrual dysfunction, when it comes to the signs and symptoms, under the signs and symptoms, you also have hyperandrogenism. So hyperandrogenism, as I have explained already, is also a sign and a symptom. Some people have it, some people don't. So when we talk about hyperandrogenism, we have the clinical symptoms, which are like facial hair, which you can have the hair, it can be on the facial, on the face, or it can be on the upper lip, okay, in the chin, on the upper lip, sometimes on the chest. So it's different for everybody. And then we have acne. Acne could be persistent and treatment resistant, like you use all kinds of creams and ointments, or you use even oral medication and it still does not work. So that is what we call acne that is persistent and it is treatment resistant. We have androgenic alopecia, where we have a receding hairline. And next, when it comes to the biochemical signs and symptoms of hyperandrogenism, we have elevated free testosterone. So when you go for a lab test, you'll find out that your testosterone is a bit higher than it's supposed to be when it comes to a female person or patient. And next, we have metabolic features, where we have weight gain. So when it comes to weight gain, not all people who have polycystic ovarian syndrome have a lot of weight, or let's say are obese or are overweight. Some people are lean and they still have polycystic ovarian syndrome, but we have a higher population of people who have polycystic ovarian syndrome experiencing weight gain, especially in the abdominal area. And the main reason for weight gain goes back to insulin resistance. So insulin resistance causes the muscle cells not to take up your glucose. So once they don't take up glucose, because insulin acts as a key or a gate for glucose to go into our muscle cell, so that when we walk, when we use our energy, we can burn more glucose, and we are able to take that out of our system. But once the muscle cells don't take up that insulin, the insulin is free. And you know what how the body responds? The body responds by producing more insulin. So once we have more insulin, now we start converting that glucose into fat. So, sorry. That is why we have the fat, especially along the abdominal area. And then we have difficulty in losing weight because your metabolism is tampered with, it's haywire. So you are not going to lose weight because even insulin is not being taken up by your muscles. You are now storing more fat than breaking it down to produce energy. That's a symptom. And then we have dark neck and axilla. So on the armpits, you might have darkness. It's darker than the rest of your body. It's like hyperpigmentation, but then you can see lines, the folds. So that's another symptom, and it usually goes back still to insulin resistance. And next, we have now the polycystic ovaries. So you can see more than 20 small follicles when you go for your ultrasound. They look like a string of pearls and they have a large volume. So sometimes polycystic ovaries alone are not equal to polycystic ovarian syndrome. So whenever you have polycystic ovaries alone, that does not diagnose that you have polycystic ovarian syndrome. We have a mechanism for diagnosing polycystic ovarian syndrome where you have like more than two major symptoms. And we have the psychological features. So when it comes to psychological features, I know somebody will talk about them later. So psychological features are usually like anxiety, depression, or your body image. You are in body image distress. Like you are very conscious of your weight. There is a fat around your abdomen. So somebody becomes very conscious of their body weight. And next, apart from the signs and symptoms, so I think signs and symptoms are very easy and straight to the point. We also have common myths and misconceptions. So there are those things that we say on social media, mostly we say in the hospital, or sometimes even your doctor might say them, but they are not facts. So we have myths and misconceptions that are concerning when it comes to polycystic ovarian syndrome. So the myth number one is that polycystic ovarian syndrome means that you must have ovarian cysts. That is not a fact. So not all women with polycystic ovarian syndrome have cysts. Sometimes you don't have cysts, but you have facial hair. Sometimes you don't have cysts, but your insulin is over the roof. So it is not everybody who has polycystic ovarian that has to have ovarian cysts. Number two is that only overweight women get polycystic ovarian syndrome. Not all overweight women will have polycystic ovarian syndrome. This is sometimes tied to genetics, so it is different. The reality is that both lean and overweight women can have polycystic ovarian syndrome. Myth number three is that polycystic ovarian syndrome is only a reproductive problem. That is not the case. You could actually be able to have your menses regularly, but you still have you still have facial hair. You still have other symptoms when it comes to polycystic ovarian syndrome, like the endocrine metabolic symptoms and all the metabolism symptoms, like when it comes to insulin resistance, majorly. Number four, we have that women with PCOS cannot get pregnant. I'm sure maybe among the guests that we have today, there is one or two people who are diagnosed with polycystic ovarian syndrome, and maybe your physician told you that you really need to get pregnant as soon as possible. I know that's what most of us say, that whenever you are ready to get pregnant and have children, you come back and then we can start from there. That's not the case. It's not everybody who has polycystic ovarian syndrome who will not be able to get pregnant. Many women with polycystic ovarian syndrome can convince, although ovulation may be irregular. So you just need enough support from all people around you, your family, your healthcare provider, to help you come to conceiving your child. And next of the myths, we have irregular periods always mean polycystic ovarian syndrome. No, that's not the case. We have other other causes of polycystic irregular menstruation, mostly linked to the endocrine system. So somebody could be overweight and therefore they have irregular menses. Somebody could just be genetic and it's not linked to polycystic ovarian syndrome. The next myth is that polycystic ovarian syndrome is rare. It is not rare. Actually, from the the demographics or the data that is provided, that it is only between 8 to 13% of women that have polycystic ovarian syndrome. That's not the case. If you are very alert, you will realize that the people around you, if you ask and they are maybe ready to speak up, you will realize that you have so many people around you who have that polycystic ovarian syndrome. So we have a larger population than we think. And I think the initiative, when it comes to our foundation here in Jonica, it's a very good initiative because that will help a lot in women who are experiencing polycystic ovarian syndrome. The next myth is that polycystic ovarian syndrome is caused by your lifestyle, that if you eat too much or you have a good appetite or like your lifestyle, you are sedentary, you don't move around, that you will have polycystic ovarian syndrome. That's not the case. But that could drive the factor like insulin resistance to cause polycystic ovarian syndrome, but that is not the only cause when it comes to polycystic ovarian syndrome. So the reality is that it has multiple causes, like a genetic predisposition. So for example, if your mother or your grandmother had some kind of polycystic ovarian syndrome symptoms, or you were born with we'll look at the causes maybe later, but genetic predisposition is one of the main causes of polycystic ovarian syndrome. And then we have hormonal imbalances, which could also predispose you, insulin resistance, environmental factors like the soaps we use and the colognes we use, the perfumes and all that, they could predispose you. And number 8 is that polycystic ovarian syndrome causes excessive hair and acne. Not all people who don't have excessive hair or facial hair or acne have polycystic ovarian syndrome. So there are people who don't have the hair, the facial hair, but they still have polycystic ovarian syndrome. They present with other symptoms. So it's different between each individual. And lastly, that ultrasound alone can diagnose polycystic ovarian syndrome. It's not only an ultrasound that can diagnose polycystic ovarian syndrome. We have other lab tests and biochemical and imaging assessments that are required for you to diagnose polycystic ovarian syndrome as it's supposed to be diagnosed. Yeah, so that's all when it comes to the definition, the signs and symptoms, and lastly, the myths and misconceptions against the facts of polycystic ovarian syndrome. Yeah, so thank you. I think I've exhausted my time. Yeah, thank you.
Wow, this is so powerful. Thank you so much, Dr. Zipporah. As I mentioned earlier, she's also one of our board member. She's also a board member at Jonica Foundation. Uh, you've done it so powerfully, taking us through the meaning, the science and myths and facts about PCOS. And to all our participants, you can write through the chat box, whatever maybe the concerns you may have, so that our speakers will look at it later. And you've done it so powerfully, and I hope we are learning. Personally, I'm getting to learn more, even as I've already gained a lot of knowledge even from these. So let's just appreciate Daktari. For those who are joining us not from from other countries. If I say Daktari, Daktari means doctor. So let's give a round of applause for Daktari. You can do the claps, use the emojis to clap for her for taking us through powerfully the first session. Thank you so much, Daktari. As we go to the next speaker. So our next speaker is Dr. Neema Chacha. Dr. Neema Chacha is a wellness consultant from Nairobi, the Nairobi Hospital, and she'll be taking us through diagnosis, criteria, ultrasound, and hormonal tests. Before I welcome her, I would like us to just do drum rolls and just claps in the using the emojis as we welcome her to take the stage and take us through that particular area. Welcome, Dr. Neema. If you can hear me, please. Daktari. Dr. Neema. Yes, let's keep the drum rolls coming, the claps, the welcome, the love emojis, as we appreciate Dr. Zipporah and welcome Dr. Neema to take up. Dr. Neema, can you hear me? Dr.
Yes,
Neema?
I can hear you. I can hear
Yes,
you.
thank you so much. Please take over as you take us through diagnosis, criteria, ultrasound, and hormonal tests. Please, let's keep our clap and love emojis as she takes over to take us through. Karibu, Daktari.
Okay. Thank you, Julia, for this opportunity. My name is Dr. Chacha from the Nairobi Hospital. The wellness consultant in the Nairobi Hospital. So I will be very brief because I'm still on duty. So I will just go direct on what I was told to do. Then I will continue with my shift. You can hear me?
Yes. Please proceed. You loud and clear.
Okay. I was told you requested to talk about the diagnostic criteria, also to talk about the role of the ultrasound, the hormonal test, and the clinical assessments. Yeah, for polycystic, for polycystic ovarian, we usually use I will use the simple language so that everyone can get and also can understand. There are some things which can make someone to know that he has a problem in the menstruation or in the cycle, the menstruation cycle. So we have the irregular or absent of the menstruation. If someone is getting irregular menstruation or getting imbalance in menstruation or getting absent of menstruation, that can make someone to suspect maybe this person has something going on, and it probably maybe is a polycystic effect. And also, for the polycystic effect is more of hormonal issues, where you get that some female, they usually get maybe a lot of androgens or a lot of male hormones than the female hormones. So when you have a lot of androgens, you can have imbalance of the menstruation, which also can lead you to polycystic effects. Also, another thing is the hyperandrogens. For hyperandrogens, you can notice someone having excessive hair growth, like when you see the legs and the hands, you see a lot of hair. For females, is not normal having a lot of hair in the body. That also can indicate that you have a lot of androgens, which also is a criteria to guide you that you have that effect. Also, another thing, maybe you can find someone having a lot of acne, a lot of maybe the face has a lot of oil face, a lot of acne, and also you get someone having alopecia. Alopecia is where maybe the head doesn't have enough hair. That also can indicate that this person has a lot of androgens, or a lot of male hormones. Also, you can send that person to do an ultrasound, where the ultrasound usually tell us the morphology of the ovaries. For polycystic, it's not exactly that you'll see the ovary, like those cysts, like a lot of cysts in maybe a given ovary. Some ovaries can be normal, but they have the same polycystic effect. So we usually use the ultrasound to check the morphology of the ovaries. Are the ovaries okay? Are the ovaries having the cyst? Are the ovaries having how is the morphology of the ovaries? Also, that one can guide us to know the exact image of the ovaries. Also, we have another thing where some females, they usually become severe masculine. You get someone having a lot, or maybe the voice is deepening instead of maybe speaking like the female, like soprano voice. The voice started deepening. They started speaking, maybe talking in bass voice. That also can indicate this person is changing from being a female to a male. And also there is increase of muscles. I think you understand by saying increase of muscles. Male, they are masculine than female. So when you see a female having a lot of muscles, you can suspect something. And also you get maybe the breast, they have reduced, the breast size, they reduce I can give an example of older females, or the old people. You get their breast, they usually disappears, and also their voice, they usually change to bass, they usually deepens. That also indicates that the feminish in them is decreasing. Now they're becoming more of male. Also, for the female, they can notice also increased size of the clitoris. The clitoris, I think you understand. Like for the male, for clitoris, it's like the penis for the male. So when you see your clitoris is increasing in size, you can suspect there is something going on. So for the clinical, or for the diagnostic criteria, we have four, which I've already explained in large. We have the regular or absent of ovulation. We have hyperandrogens, or increase of the male androgens in the body. Also, we have the polycystic ovaries, and we have the severe masculization. So, as I explained earlier, the other one was the role of the ultrasound. As I said, we usually use the ultrasound to check the morphology of the ovaries, but it's not exactly that it will give you the direct, it will not tell you exactly that this person has the polycystic, because some ovaries can be normal in size, normal in shape, normal in morphology, but still that person has it polycystic. And also we do the hormonal test, where the hormonal test, we usually check the level of the androgen, level of the testosterone for the male hormones. And also we check the level of the luteinizing hormones, the level of the estrogens for the females. If for the females have decreased compared with the males have increased, that also can give you a clue this person is moving towards the male side instead of being the female side. And also we do the clinical assessments. For clinical assessment, we usually check the symptom signs and symptoms, and also the presentation of that patients. So as we have discussed, for polycystic is not a direct diagnostic. like you can't just this person has this. It's not something which you can just direct say this person has this. You have to do a lot of investigation. You have to be to take a clear symptoms, clear history, clear everything, like how it started, how is your menstruation, how is everything. Then you can conclude this person has the polycystic ovarian symptoms. I think I think I've done with what I was asked to do. Juliet, if there is anything, maybe we can continue with the discussion. I want to continue with the shift.
All right. Thank you so much, Dr. Nema, for taking us through that session of the criteria, diagnosis criteria, ultrasound, hormonal test, and just taking us through that session powerfully, adding more information. You've done it so powerfully. For allow us to say thank you, and in the let's do our normal culture. We can send some love emojis. We can do a round of applause. We can clap to appreciate Daktari or Dr. Nema for taking us through that particular session. And she's based at the Nairobi Hospital. So in case maybe you need to get to interact with her for more information and all that, she's available. And as we continue also through the interaction, we'll get to ask the concerns and questions that we may have. Thank you so much, Daktari. Allow us now to thank you. Keep the love emojis coming. Keep the congratulations and the claps coming. We're doing well. Thank you so much, everyone, for keeping the webinar active and just being alive, lively in the webinar. Thank you so much. Now we are moving from Kenya. We're going to Ghana. So now we are traveling to Ghana. We are flying to Ghana. So on to our next speaker. She's Ajewa Ankoma. So I hope I pronounce well, but if I'm not pronounced well, she will help me. And I know she will not get offended. She will help me pronounce that. Or I'll call her Ajay. So Ajay is a PCOS advocate, a lifestyle. So she's going to take us through lifestyle and mental health, living with PCOS. So for us who are in Kenya, we'll say Karibu. And for the purpose of everyone getting involved, allow me to say welcome, Ajay. Please take the stage. And as she takes the stage to take us through the lifestyle and mental health, living with PCOS, please let's do our normal culture. Let's clap. Let's do some good love emojis, good welcome as we welcome her to take the stage and take us through the next session. Welcome, Ajay. Please, if you can hear me.
Thank you.
Can you hear me?
Can you hear me?
Yes, please take over.
All right. Thank you, everyone. And I'm very grateful to be here. So the name is Ajewa Ankoma. But it's a Ghanaian name, obviously, and pronouncing it is a bit difficult for people who are non-Ghanaian. So I don't have any problem with the mispronunciation. So you can simply call me AJ if you're finding it difficult to mention the name. And I'm a polycystic ovarian syndrome advocate, just as Juliet introduced. And I'm very glad to be here. So I'd like to thank each and every one of you here, especially Mrs. Veronica Johnson. She reached out to me to join this webinar. And whenever the opportunity presents itself for me to talk about PCOS, I do it fervently because I know how PCOS has impacted me, and I want to advocate for better healthcare for everyone with PCOS and also spread awareness about the condition. So let's get right into it. But before that, today is Ghana's Independence Day. That's why I'm repping Ghana. So I'd like to say Happy Independence Day to my Ghanaians on the call. Ghana is 69 today. Happy Independence Day. Yes, that was just by the way. So I'll get into the presentation. And just as Juliet mentioned, I'll be presenting on the intersection of lifestyle, mental health, and medical care among PCOS patients. And I think Dr. Zipporah and Dr. Nima have done extremely well. They've done 80% of my work for me, so I'll just be doing 20%. But it would be substantial also. So let's get right into it. I'll share my screen because I have a presentation to present. So let me share. Just a second. All right. Can you confirm whether you see my screen?
Yes, I can see your screen.
All right.
Yes.
Okay. So let me, I have to see. Sorry. So just as I mentioned, this is the discussion, this is my part, and these are the content. So we are going to talk about comprehensive PCOS treatment, how we can clinically manage PCOS, how PCOS and mental health are connected, how we can also manage PCOS. So the first is comprehensive PCOS treatment. So Dr. Zipora already mentioned that usually when people hear of PCOS, they think it's just a reproductive condition, but we've already debunked that myth that PCOS is not just a reproductive condition. So someone with PCOS may be going to the hospital to see all these healthcare providers. So if there is a case of extreme skin issues like acne, the patient may be seeing the dermatologist. If there is, and 80% of the time or almost every time, there is a hormonal imbalance issue, so the patient will see the endocrinologist. The patient may want to have a dietary plan customized for themselves alone. They may have to see the nutritionist or the dietitian. So with the issue of screening for policies or anything about the reproductive system, the patient has to see the gynecologist. And also with the topic for today, mental health, the patient has to see the therapist. So usually PCOS is treated in silos, but it's recommended that we treat it holistically. And as of today, there is no one size fits all treatment for PCOS. So if a patient has PCOS and they show all the symptoms that we already made mention of, you have to unfortunately see all these see all these healthcare providers. And I'm saying unfortunately because it comes at a cost. So it may get a toll on your economic status. So we move on to how to clinically manage PCOS, and that is going to give you a long-term quality health. So doctors have already made mention of the clinical symptoms, and I'll touch a little on it. So there is irregular cycles, there is hirsutism, there is weight gain, acne, insulin resistance, mood changes, and even more. So how can we deal with these clinical symptoms? We have to intervene early. So if you have PCOS, the moment you get diagnosed, you have to look at your lifestyle very well. You don't want to be living like anyone else. So when I got diagnosed first, I already I was very cautious about my lifestyle, the diet, my being physically active, but I had to be extreme. I had to go on another level when it comes to my lifestyle. So now I had to cut down on a lot of things that I used to eat, processed foods. I had to increase how physically active I was before. I had to include a skincare routine because I suffer from acne and all that. So we have personalized treatment, which is also beyond the universal pill approach. And I already made mention of the fact that there is not a one size fits all medication for PCOS as of today. So if you have PCOS, it differs in individuals. So you may have to have a personalized treatment for you. That's why you have to go to the hospital. So when you go to the hospital, there will be treatment curated for you. So if you have acne, if you have insulin resistance, if you have hair growing on unwanted parts of your bodies, there is going to be personalized treatment for you because there is not an exact treatment for everyone with PCOS. PCOS manifests differently in every patient. So with the long-term health, PCOS can actually be debilitating. So if patients are not treating or are not managing their PCOS symptoms very well, it can lead them to chronic diseases like type 2 diabetes, cardiovascular diseases, hypertension. And this is not what we want to have. we want a very quality health. So if we have PCOS, managing it early can help us prevent all these debilitating diseases. So giving quality health and also promoting positive mental health outcomes. And people may think we are exaggerating when we talk about the mental health aspect of PCOS. Some just say, oh, it's in your head. It's not that deep, but there is more to it. It is not just the surface that we see. It is an imbalance of hormones, cortisol. Cortisol is a hormone. So all those hormones, dysregulation of them can cause a toll on the mental health of the patient. So we move on to how PCOS and mental health are connected. So just as I just mentioned, when your cortisol levels are high, when there is a dysregulation in your insulin levels, it creates an imbalance in your system. So there is high hormones where there is supposed to be a stabilized hormone. There is low hormones where there is supposed to be, the hormones have to be balanced. So when some are high, some are low, and they are not balanced, there is definitely going to be a dysregulation in your system. And when there's an imbalance like that, it will definitely manifest on the individual. So when people talk about their mental health, it is not just in their head once again. Also, the very obvious one, if somebody has PCOS, I'll use myself as an example. So then I hadn't even been diagnosed of PCOS, but it started manifesting as severe cystic acne. It was really severe. And I have some of my people from Ghana, my family, close friends on the call. They can attest to the fact that I really suffered severe cystic acne. And people would just meet me and ask whether I had even committed a sin, whether it was something else, because it was that severe. And it affected my mental health, my body image, my self-worth. Opportunities that I was supposed to embrace, I shunned from them because my body image was compromised. And it affected my relationships. For someone like me, I'm very lively and I light up every room that I enter. But when that happened, I couldn't recognize myself, and the people around me couldn't even recognize me anymore. So PCOS affects people's body images, affect their self-worth. So when everyone or any patient with PCOS talks about the mental health aspects of PCOS, please let's not undermine it because it can go to that extent. So now we talk about how to manage PCOS. So if you have PCOS, you have to have a routine, you have to have a curated management for yourself. So in order to have a sustainable lifestyle, you have to have a gentle nutrition. What do I mean by a gentle nutrition? Diet is a very sensitive topic to touch on. But if you are eating all those ultra processed foods, if you are eating like everyone else, just know that it is not going to work for you as someone with PCOS. Even as people with PCOS, the hospitals, healthcare providers will not even advise them to eat these ultra processed foods a lot. How much more someone fighting PCOS? So you have to work on your diet. You have to restrict yourself from eating ultra processed foods. You have to, go that approach so that you can support your hormonal system, your endocrinological system. Endocrine system, sorry. So the strategic movement we have where people go to the gym to drive their fitness journey. But for instance, I do walks, I take walks, and it's also part of the fitness activity. So it's helping me to maintain my balance. It's helping me to move more and to help me have a sustainable lifestyle. So we talk about holistic care, which is for healthcare providers. So holistic care, going to the hospital, if healthcare providers are just doing blood works, it's not going to work. They have to screen for mental health also. And I would also use this opportunity to make a clarion call to healthcare providers. If you're a healthcare provider on the call, please don't just talk to the patient as though PCOS is just about the reproductive system, and don't just limits PCOS to the reproductive aspect. So if somebody has PCOS, treat it as a holistic condition, treat it holistically. So you must check their mental health. You must make sure they are not going through it mentally. You must make sure the hormones are balanced in all aspects so that it doesn't have a toll on their mental health in the long run. So we also have advocacy, where there is a community-centered advocacy where everyone joins in. So it's not just for patients, partners of the patients can join in, families, friends, advocates. I believe that all of us are, we all suffer from the experiences that people with PCOS have. So if you are a friend, you have at least a second-hand experience of someone with PCOS, because if they are going through it and they have mood swings, it may definitely affect you. So if we are talking about PCOS, if you are creating awareness about PCOS, please join in and let's all advocate to raise awareness for a better health care for people with PCOS, and also for raising awareness, because a lot of people still don't know about PCOS. And we should know that PCOS is not just a syndrome. It is managing PCOS is not just as we aren't just managing a syndrome. Let me read it out. We aren't just managing a syndrome. We are supporting a whole person. So it is not just a syndrome. It is not just you helping raise awareness about a syndrome. It is you helping someone else, supporting the person wholly. So if you love somebody, if somebody is your friend, you care about them and they have PCOS, joining in can help us support them holistically. So thank you so much for this opportunity, and I'm very grateful, and I hope everyone has learned one or two from what I've said.
Thank you, AJ, for such a wonderful presentation. For any questions, you can just highlight on the chat. Also, so we are going to go to the next section, which is the poll. Sorry for that. So in case of any question, you can always ask kwa the chat. And also for the first few or three speakers we've had, what have you learned? What's something interesting that you've actually found out from the presentation we've just had? You can also highlight that on the chat box as we continue to engage with you guys. Yes, thank you.
All right, so we are taking a short break of around 5 to 6 minutes. So meanwhile, as we take the short break, you can have a look at the poll, and you can scan and just follow and answer what is displayed on your screen. And meanwhile, as our speakers take a cup of water or sip a cup of water, something, and then we come back in the next 5 minutes to proceed. And also keep your questions in the chat box as we, if you are able to bold enough to speak, we'll have a Q&A session. And I've also noted some of the questions which are coming in, so please keep them coming. I've noted down, so we're not assuming we'll answer them shortly. And just keep the chat active. Share your comments, share your thoughts, and we'll be able to gladly respond to them. So we are taking a short break. We'll be back in the next 5 minutes, but you can have a look at the poll meanwhile. Thank you. All right. Welcome back, and thank you so much for. You can keep responding to the poll. Thank you so much for staying with us and keeping the conversation active and just being lively and engaging. And we are happy to have you all because we couldn't have such a wonderful webinar without you. Thank you so much for joining, and we are still responding to your concern. We're seeing the questions you're sending on the chats and the compliments. Thank you so much. So we are going to the next session, and I'll welcome my colleague Jeanette to proceed. Jeanette, can you hear me?
Yes,
Jeanette?
yes, I can. Yes, I can.
Okay. Thank
Okay.
you. She's taking over from me. Thank you so much, and keep the conversation active.
Thank you very much, Juliet. Good afternoon once again, everyone. You can continue participating in the poll that's displayed on your screens. So for the next section, we're going to have the lived experiences from some of our speakers. So we have 3 of them. Each everyone will have a few minutes to give their experience on PCOS and how they've been handling it, the challenges, the good part of it, the bad part, everything in between. So we'll start with either of the 3 that are here. If any of you can hear me, you can respond so that we can begin. We can start with Esther Amwea. Is Esther available? So she seems she's not here. So we'll have the second person with the lived experience to tell us more about it. Can they hear me? Our 2 speakers?
Yes, we can hear you.
Okay. Okay. Sawa. So for the lived experience, the floor is yours. Thanks. Okay, so it seems like our speakers are not here for today. Sorry about that. So if anyone is willing to share their journey with PCOS, can do so now, so that we get to understand and learn more on the PCOS. Yes, thank you. If anyone wants to do so, you can just unmute and you can go ahead. Thank you. Or you can also raise your hand, and then you can go on.
There's a hand up from Emma.
Okay, Emma, you can go on and share.
Share or ask questions?
Just to share your story, or you
Oh,
can
okay.
just yeah.
It's not my story, but I do have a sibling, an older sister that suffered from PCOS, and it was extremely challenging emotionally for us as a family. but also financially, it really impacted us because of as I think the Ghanaian lady, I can't remember her name, but she gave a good description of the different specialists that we had to see, which was extremely time consuming and again expensive. And just going to the hospital multiple times and not getting definitive care was really, really difficult. It got to a point that even, her significant other had to leave because the disease had really taken a toll on almost everyone, me included. So I guess now I'll just wait for the question and answer session because I do have a couple of questions. But it's not as much as I do know we have people who are living with it. My sister, luckily, she was able to undergo surgery, so she does not experience PCOS anymore. She had an ovarectomy. I think that's when you remove the ovaries. And so she's doing quite well right now, but it's not a light condition to take, and I don't think there is enough awareness and education in the African context of how this disease actually affects women and the relationships that they have. So yeah, I think that's all I have to share.
Okay, thank you very much, Emma, for story that you've just shared, and at least we've gotten more insight on the challenges that the PCOS advocates actually face. So as we continue, I'd like to invite AJ to actually tell us more on the PCOS, as she's an advocate for the same. She can share her experience for just a few minutes and then we can continue. Welcome, AJ. Thanks.
Hello, can you come again?
Pardon? Okay. Can you hear me?
Yes, I can.
Okay, thank you. So we've just had a piece of the lived experience from one of our speakers, Emma, and we are glad she's shared that. Also, we wanted you, AJ, to share your experience on the same, since you're an advocate for PCOS, and we will get to learn more on it and understand it better.
Okay, so
Yeah.
my lived experience with the condition with PCOS, I got diagnosed in 2021, but I had read about the condition in 2017 when I started having symptoms. So my symptoms ranged from severe cystic acne, as I already mentioned, and my cycles. So I used to bleed a lot. So a day I could use a pack of sanitary pads that had like 12 single pads in it. So mine was over bleeding. And at a point, I was also seeing my periods. So they were erratic. They were not, regular. So, and after I got diagnosed, I saw that awareness was very low, because when I told the people in my circle, I'm usually stingy when it comes to information about myself. But when I told the people in my circle and I realized almost every one of them hadn't heard about the condition, I saw that awareness was really low. So I had to take it upon myself to start an advocacy. So that's how come I started advocating about the condition. So some of the challenges we face, I'm sure Emma, I don't remember if it was Emma who spoke previously, but some of the challenges we face, one is the stigma. So yesterday I was even at an event and I introduced myself as a PCOS advocate. And someone walked to me after the event and asked how brave I was to start an advocacy of such, because the person thought that if you have a condition, you shouldn't really speak about it, a medical condition actually, you shouldn't really speak about it. And I told him that it is not about glorification of any condition. We are just creating awareness, because he, for instance, didn't even know about what PCOS is. He hadn't even heard about PCOS before until yesterday. So I told him about the fact that we are raising awareness about a medical condition that affects about 1 out of 10 women worldwide. So when you take 10 women, or when you see 10 women, out of them, 1 may have PCOS. And you see the symptoms that we raised awareness about. So if you have a woman suffering from hirsutism, hair growing at unwanted parts of their body, if they have beard, you know how that comes with body image issues. If they are overbleeding like I was, if they're not seeing their cycles, you see how disturbing and depressing that can be. If you have a woman who is really forcing hard to lose weight and they're not able to lose weight, you know how depressing that can also be. So if you see people going through such a condition, is it not best of you to raise awareness about it, to educate people about it, so that if policies can be put in place to help better, to drive a better healthcare for these people, why wouldn't you join in such an opportunity, right? So one of the backlashes we face, I personally have faced this, people thinking that I'm glorifying a medical condition, but it is not so. And also in Ghana, I have tried going to schools, to girls' schools, secondary schools, basic schools, to raise awareness about the condition, but I've not had the opportunity because of bureaucracies and other reasons of the institutions. So it is also a challenge that I personally have been facing for quite some time. So I started my advocacy in 2024, and since 2024, I've had that issue, I've had that challenge. So I've not been able to do it to my expectation. So it's also a challenge. And also as a patient, when it comes to research, I see that it is slow, and I don't think nobody in particular is to blame. Women's health has always been sidelined, so to speak. And as a patient and an advocate as well, it is a challenge. So there is not much research about the condition as there should be, because women go through a lot. The woman body goes through a lot of complications. So there should be funds in research allocated for research about conditions like endometriosis, PCOS, fibroids. So all these are challenges, and I wish funds could be pushed in for more research on PCOS, especially since it's a syndrome. We don't even know what causes it. It ranges from one person to the other. It's a syndrome, so it's not the same in person A, and it's different in people. It manifests differently. So if more could be pushed in, research, awareness, education, and all that, we would be very happy. So these are some of the challenges I face as an advocate and as someone with PCOS.
Thank you so much
You're welcome.
for that. And thank you for sharing your experience and the challenges that you've experienced in Ghana. I mean, I think for most, especially African countries, experience is almost running the same thing in terms of advocacy for the reproductive health issues such as PCOS. And I hope the near future, the government can actually see the necessity for either funding and just advocating for better healthcare geared towards eliminating and the PCOS and other reproductive health issues. So as we continue, we'll go to the Q&A. for this session for about 5 to 6 minutes or so. So if any of you has any question, you can either post on the chat or raise your hand and ask your question, and then our speakers will gladly respond to the questions that you have. So if you had already posted your question on the chat, we can look at that, and then we can go ahead and the others can go ahead and ask their questions. So I can see one question from Teresa. She asked, is there a common shared symptom for PCOS? If any of the speaker can answer that, it will be appreciated. We can have, okay, yeah, it's okay. AJ, you can go ahead.
Okay, so common shared symptom, I would say hormonal imbalance, because almost everyone with PCOS has a dysregulation in their endocrine system. So hormonal imbalance, which doesn't manifest physiologically, because, you know, if there is a dysregulation in your hormone, it can appear as acne, which may not appear or manifest in another patient. It can cause difficulty in losing weight, which may not manifest in another patient as well, hirsutism and all that. So hormonal imbalance is like, it sets the stage for the manifestation of the other symptoms. So I think hormonal imbalance is the most common symptom amongst patients with PCOS.
Okay, thank you for that, Teresa. I hope your question was well answered. There was another question from Rosina Ngema. They had asked, what kind of psychosocial support do patients and families need most? Sorry for that. Dr. Zipporah, if you can kindly answer that.
So the psychosocial support that we can have from our family and friends is mostly counseling, and especially due to the stigma. So because of the stigma, you actually need somebody who can accommodate your fear, because there's that fear of infertility, the fear of not having children. Maybe, for example, if you want to have some and you don't have yet, and then not having your periods, they're very irregular, having facial hair. So such things, you need counseling, you need patient education. So have people around who can give you the right education, because once you know what causes what, and then you're able to change your lifestyle, just as AJ has said, and be able to live through it, is to have a supportive system that understands and that accommodates your fears. Because you have fears, being honest, you have fears and you don't want to even speak about them, but having people around you whom you're able to speak to without feeling stigmatized is a very good thing.
Okay, thank you for that, Dr. Zipporah. I hope your question, Gemma, was answered well. So there's a comment from Emma, and she said that stigma is crazy, especially in our African culture. They say someone had cast you or done witchcraft on you, and that's on having PCOS. Another question, we have several questions, 4 of them. So we'll start with the first one from Stella Wamoyo. Are there supplements that are scientifically proven to help with PCOS? Dr. Zipporah?
Yes, we have a supplement. We have a supplement that is a B complex. It's under a group of vitamin B complexes. It is called, what is that name? Inositol. So we have inositol works. When we look at the studies that we have around now, inositol is actually functioning better than metformin. So inositol has very good results when it comes to polycystic ovarian syndrome clients and patients, and in the right ratio. So maybe when you come to education, when it comes to treatment, you have to have myo-inositol and chiro-inositol. Most of the time, it should be in a 40 to 1 40-to-1 ratio. And this 40 in a day should be 4,000 milligrams over the myo-inositol, and then it should now be 40-to-1 to the chiro-inositol. So that is one supplement that I can vouch for. I can say that. Apart from that, we have other supportive supplements, but I can say that is the main one. Maybe you can talk about the other some other time, but we have berberine. Berberine is also good, but the manufacturer can tamper with the stability of berberine such that you will take berberine over a long time and then it doesn't give you the results because it is not stable. Like the moment you take it to your, when you take it with your food, now that supplements are taken with your food, it doesn't work because it is maybe thermolabile, like it is unstable in high temperatures or something like that. It has been rendered inactive during manufacturing. So that's another thing about supplements. You have to be careful what you are buying. But we have a number of them, like something that helps with inflammation. Turmeric and ginger will lower the inflammation and therefore lower some symptoms. Yeah, we have a number. Maybe you can talk about them some other time, but those are the few ones that I know actually work and have a good backup from the studies that are shown.
Okay, thank you for that, Dr. Zipporah. We have other 4 more questions, and we close the Q&A part. So the second one is, what is one thing you wish every woman with PCOS knew earlier about managing the condition? I guess I'll give this question to Dr. Chacha to tell us more on that. Dr. Chacha, are you here? Okay, then Dr. Zipporah, if you don't mind, can you answer that question?
I think maybe one thing that I can tell somebody who already has, and maybe they could have noted it earlier, is don't assume the irregular periods. Like you have oligonorrhea where you don't have your periods or menses for like 3 cycles, that is 3 months, and you realize there's an abnormality, there is that tendency to ignore and wait, and then maybe it turns to 6 months of irregular cycles. So once you get that irregular cycles and it's more than 3 months, look for a medical practitioner and find out what's happening to your body, because the longer you wait, the worse things become.
Okay, thank you for that. We have another 3, the last one. Why does it take long for diagnosis, and how can the health system improve? I guess that we can give that question to AJ to answer. And then the other question will be, how does incorporating mental health look like in practice? Yeah, that can go to Dr. Zipporah. Yes, thank you.
And was the question how or why?
Why does it take long for diagnosis, and how can the health system improve?
I think because as it stands, the Rotterdam criteria is what is used to diagnose PCOS. So if a patient has 2 out of 3 of the criteria, then they are going to be diagnosed of PCOS. But there are times that, if a patient is not experiencing, let's say, as it stands, or right now, I am not experiencing severe cystic acne, and I go to the hospital and there are no cysts also on my ovaries, that means 2 out of the 3 are cancelled. So maybe it would be left with just 1 of the criteria that I would tick. So if that's the case, definitely it would be ruled out that I don't have PCOS. Also, the monetary aspect, so the economic aspect of it. If a patient has to go to the endocrinologist to check their hormones, if they have to go to the gynae to check their reproductive system, if they have to pay all those sums of money, those amounts of money before they can get a diagnosis, it delays it, because not everyone is financially capable to visit all these healthcare providers. So it's also one of the reasons why patients don't get their diagnosis early. Also, opening up is sometimes an issue because people are afraid of being judged. For instance, when I was experiencing overbleeding, I kept it to myself for some time before I went to the hospital. And there are people who don't see their periods and they also shun away from visiting the hospital because of the false impression that some of these healthcare providers may unethically, portray. So, in our African community, if you miss your period and you even discuss it amongst people, you're definitely going to say that you've had, especially if you're not married, you've had premarital sex. So there are people who would also not visit the hospital because they may be having premarital sex, all right, and the fear of being judged is the reason why they wouldn't visit the hospital, so that they would not be judged. So all these things, and the stigma also, so the stigma that it comes with, if you have to discuss with people that you go through all these symptoms or some of these symptoms that seem gross to people, you'll be stigmatized. People are going to look at you in a certain light. So people also don't share, and it delays diagnosis because they have the fear of being stigmatized.
Okay, thank you for that, AJ. On the last question, which Dr. Zipporah will handle, how does incorporating mental health look like in practice?
How does incorporating mental health look like in practice? Mostly it is how can I say, going for counseling, but it's not very common. That's the reality. It's not very common to assign a psychologist or a psychologist for somebody with a diagnosis of polycystic ovarian syndrome as part of their management plan. Yeah, but that should be the case, but it's not.
Okay, thank you for that. I can see Faith Ochara's hand is up. Faith, if you can hear me, you can
Yes.
ask your question.
Good afternoon, everyone, and good morning, wherever you are. I just have a question specifically on sensitization, and this is directly to the Jonica Foundation. In terms of what are you guys doing so that we ensure that everyone on the ground, I mean people who are living below the dollar sign, that they can get sensitization about PCOS. We have a lot of people who still mock women who have facial hairs. So are you guys thinking about media tours, press release, or conferences that can address this community sensitization? Are you guys thinking about consortiums with other organizations, also even the Ministry of Education, either in Ghana or Kenya? So what are you guys thinking or doing in terms of addressing those gaps? Because I understand that in every community we have what we call, what are they called? This, I'm forgetting the name because I want to really speak that word in English, but we have those women in hospitals who are assigned, like they have houses, their units, they go door to door to give the immunization and all that. Are you partnering with such people so that they can talk to women about PCOS so that we could make this conversation? Are you guys having hashtags to talk about PCOS so that more people can engage in the conversation to understand? Because we still have a lot of people who mock women. Personally, I thank God that I have insurance. Buying this medicine is expensive. Inositol is not cheap for the people who cannot afford. Metformin is not cheap. Letrozole is not cheap. So the diet, there's a diet that we have to follow. The common people, they cannot afford this. So what solutions in terms of that? Because apart from educating people about PCOS, the people who cannot afford this medication, what can they be told, especially about nutrition? There are some foods they're supposed to stay away from. To be very honest, they cannot eat wheat. They're supposed to be told things like arrowroot is good for them. So what are you doing in terms of addressing that? For us, most of us are policy makers, so as we can afford. But the people below the $1 sign, which is the larger majority in all the countries that are represented here? So that is the bigger question. Thank you.
Thank you, Kate. I hope you can hear me. It's a bit rainy on my end. I'll give that opportunity to Veronica, the Jonica Foundation founder, to answer the question. Thank you.
Thank you so much, and thank you, Faith, for that question. So I'm going straight into the first question that you've answered on what other awareness that we conduct with regards to PCOS. So we have a lot of avenues that are opening up with regards to awareness in the community. Like when we started, we mentioned that we are currently in Nairobi, Kiambu, and Kilifi, Narok, and in Homa Bay, so that is 5. So we still have limited resources to help us expound further, but we have arrangement of conducting community dialogues with the community to help them understand the PCOS and also to help us understand how can we help the community at large who are being affected by PCOS. And then when we go to the hospital, rather assisting the PCOS patients, we are looking forward to partner with healthcare facilities to offer discounted services to patients of PCOS, and also to offer sometimes free screening and also advocacy at the same time at their facilities. And also we are looking forward at a scenario where we are going to also develop a policy that states that PCOS is also an SRHR component that must be given a priority. So a lot is in store, and for those who are in the community, we have a lot in store for with regards to PCOS, and it also depends with the resources that we'll have at hand during that time. I think when you mentioned the what is it called? The healthcare providers that at the community level, that they're called the CHPs, that is community health promoters. We have a program for them where we will conduct a short training, especially on PCOS, on infertility, on menopause as well, because they are almost connected. Women health well-being. So we'll be training them on the same, and then they'll be offering these services at the grassroots level where they are. So I think I've really tried to answer you, but we are open for partnership and collaborations with organizations that work under SRHR, especially on women's health. Thank you.
Thank you for that, Veronica. I hope your question was well answered. Also, the last question from Rosina. Are there opportunities for joint programs, awareness, events, and also if you have any education materials to be shared with the community? Yes, Veronica, kindly answer. Yes, thank you.
Yes, like I finished with my last statement, we are very much open to collaborations, and if you have you have an organization that works under SRHR and you have a program that is similar with ours, we are open for conversation. You can just send us an email at info. Juliet, you can help me write the email on the chat box, info@jonicafoundation.org, so that we can see areas of shared interest, then we work together. Yeah.
Okay, thank you very much. So that was our Q&A session, which has come to an end. As we wind up with the webinar, we'll have the last part of it, which is to just inform you that we have a support group, a WhatsApp support group for the PCOS warriors. We'll share the link at the chat box for everyone. Also, we'll share our contacts for the same in case you want to reach out. Yes, so thank you very much for joining us and for making this webinar a success. And I hope we've all learned something new and something that we can all share with our loved ones, the people close to us who are experiencing this, and just champion for better reproductive health, management, and advocacy. In case of anything, you can always reach us on the number on WhatsApp too. You can join the WhatsApp support group, and also you can engage with our website to learn more about the Jonica Foundation, and we hope to interact with you guys soon and soon. Thank you very much.
I forgot to add, sorry, Janet, I forgot to add that we also have, we are looking for PCOS advocates in the 5 counties mentioned. So if you are PCOS and you want to advocate for us, we're looking for somebody with leadership position. With leadership, I mean you have a connection in the county where you are with regards to Ministry of Health, or you are a leader, you are a feminist at the county level, and you also want to be a PCOS advocate. For PCOS advocate, doesn't need for you to be a patient, or rather a victim or warrior. You can also be at some point you are guardian of a PCOS patients. You yourself, you are a PCOS patient, or you are a warrior at the same time. So we are looking for these people, and the link is on our social media pages. So if you really interact well with our social media pages, you will find the link. Let's all share it with everyone. Then we, at that point, we're going to answer the Faith's question on how do you work with the community. So that is our first point of interaction with the community. Thank you. Proceed, Janet.
Thank you guys so much for attending the webinar. And for, as I had said before, for any question, you can always reach out on the website, on the email, on our phone number for any questions in regards to reproductive health. And thank you. That was my time. I'm Jeanette. Yes, thank you. And have a good evening.
We are going to have a Thanksgiving from, or rather a vote of thanks from our chairman, so that you get to understand the. Yeah.
Okay. Just right back to you, Janet. Can you hear me very well? Hello?
Yes,
Yes,
we can hear you,
we
but
can
you are
hear
too
you.
far.
Hello.
Yes,
Okay.
but not that loud, please. Try adjusting your volume or sound. Please pick up. We lost you,
All right.
Dr. Shola.
Okay, thank you very much, everyone. I want to say a special thanks to all the participants. Thank you. We really appreciate your presence. And a special thanks, a big one, thanksgiving to all our speakers. From Aji, thank you. Thank you so much for your time. Thank you for your presence. Personally, I really appreciate all you've done today. And to Dr. Nema, thank you so much, ma. I understand how busy consultants used to be. I understand their busy schedule, but out of your busy schedule, you still find time to be part of this. I want to say a very big thank you to you. And a thank you to our board of directors, Dr. Zipporah. Thank you so much. Thank you. It's your call. It's your foundation, but at the same time, you still did a very nice job. Thank you, everyone, for all the anchor, the host, Janet, Juliet, all of you, Beth, thank you. So on behalf of Jonica Foundation, all the board members, the staff, the entire staff, and everyone involved in Jonica Foundation's job, I want to say thank you to you all. Thank you. We shall meet again on another program. by God's grace. Do have a lovely day ahead. Thank you so much.
Thank you. Let me take it from here. So thank you so much, everyone, once again. And this is our first webinar. A lot is going to come. We'll also be hoping to be hosting workshops. That some might also be physical, and most of them will be online, like we have this one. So because you've been our first participants of our first event, we will continue to interact and also to collaborate in different areas of our work. You can go to our website and learn more about Jonica Foundation and what we do and how we can collaborate as well. So thank you so much. We've come to the end, and see you when we see each other again.